So thank you. Thank you for the opportunity. It's really an honor to be here today and just to discuss the Epoch Trial. And Danielle asked me to hold my comments about 15 minutes, which I think is perfect. And so the Epoch study was really a decade worth of work on my part and others. And you saw that in the JCO, of course. And I wanted to highlight that it's a randomized trial in patients receiving CERT in the second line in patients that had progressed, not failed chemotherapy, but true progressors and tolerated chemotherapy. That's an important distinction. So you guys know this better than anybody else. We talk about the continuum of care, but we know that the number of people that receive the number of lines decreases. This is a slide from Dirk who gave me that goes from 100 to about 25% drop off every time you go from line to line. So yes, the continuum of care is important, but only 22% of patients benefit all the way up to fourth line. We know that obviously CRC is an important, there's a lot of patients that are going to suffer from this, and we need new therapies to that. But one thing I wanted to highlight is about 10, 12 years ago when we designed the trial, we recognized that metastatic tumors in general are hypervascular. They are not hypovascular. It's the degree of vascularity that matters. And so they are certainly not HCCs or metastatic renal cell tumors, but they are hypervascular, and that's why you see the responses. The Epoch trial was designed in 2010, and that's why I'm always interested in criticism and constructive commentary on the study that we designed. It was designed in 2010 in patients that had progressed on first-line systemic chemotherapy with the inclusion criteria that you see here, regular ones that you might expect, with liver-only or liver-dominant disease. At the time, the stratification we had was unibilobar disease, KRAS status, and first-line chemotherapy. The study enrolled 428 patients, randomized here to add Y90 in the second-line setting, to then receive standard second-line chemotherapy and followed per routine standard of care. So this is 2010. This is a recruitment, so it was mostly UK, US, and a lot of European participation, but ultimately 428 patients were randomized. One of the things that we had a challenge with was the extrahepatic disease, as I'm sure you see in your tumor board all the time. Whether something is a true extrahepatic lesion is always in question. And so we made sure that we confirmed to the best of our ability that the person did not have extrahepatic disease. The primary endpoint at the time was selected to be progression-free survival, with a second primary endpoint, not co-primary, but a second primary endpoint of hepatic PFS. And this was by blinded independent central review to maintain complete independence. One of the two endpoints had to have been positive, statistically significant for the study to be positive. And of course, you have your usual secondary endpoints here, OS, ORR, et cetera. I'm not going to go through the statistics here. They're well described in the manuscript, but again, it was a hierarchical design to basically, once you have your primary endpoints that are met statistically, then everything can be assessed using that hierarchy. This is the Consort Diagram, and you can see here how the patients were randomized and some more detail about each patient. Of important note, 13% of the Y90 group never received Y90 for a variety of reasons that include shunting, technical issues, et cetera. So an important nuance that I'll discuss a little bit later on. One of the things that we are particularly proud of in this manuscript is the very detailed lesional and tumor information that I think are often lacking in many of these clinical trials. The degree of bilobar distribution, the size of the tumors, the number of the tumors. And I want to highlight here that, despite the criticisms of this study, these are very advanced patients. 80% had bilobar disease. 67% or more had lesions 4 centimeters or more, and 60+% of patients had 6 or more tumors. So this was a very advanced CRC patient population. The patients, as I mentioned here, 13% never received the Y90. They all received their standard second-line chemotherapy, and there was no need for a dose reduction. One of the challenges we had up front was making sure that patients would not need a dose reduction, which is something that is challenged often when you combine therapies. Also of note, because of the intention to treat model and the fact that with CERT you need a diagnostic angiogram, the median time to Y90 was a month after the randomization, up to 3 months. So there was a delay in the time when patients received their Y90. So for the first month and a half, the two arms are essentially identical, and the difference comes in after the Y90 is implemented. The first primary endpoint was met. The hazard ratio was 0.69 and was statistically significant. Something happens here at the median. It's less than a month, so it's unimpressive, but the hazard ratio is quite compelling with a 31% risk reduction of overall systemic PFS. Notice here that the survival curve has much longer follow-up in the Y90 arm, in the CERT arm, than in the chemotherapy arm. This will come into play a little bit later on. Secondary endpoint was also met with a hazard ratio of 0.59, so a 41% risk reduction of progression in the liver, with about a 2-month improvement in the median. This is also described in the manuscript very briefly, some subset analysis, who benefited compared to the other group, the mutant types, the left side, the tumor burden here that was low, that might be expected, receiving a biologic agent as part of second line, and of course, fewer lesions, although these are just hypothesis generating observations. The overall survival as a secondary endpoint was not met. Of course, we had the hierarchical design, so any test after that is just hypothesis generating. So the intention to treat overall survival is 14 versus 14.4 months. In the per protocol analysis, though, the Y90 arm is 15.2 months versus chemo 14.3. All hypothesis generating observations, but no improvement in overall survival. If you look at the response rate, there was a 70% improvement in response from 20% to 34%. The absolute difference is only 13% or so. So there is significance here, but it's nominally significant because of the hierarchical design. You cannot declare significance here, but these are the responses that you can see when you look at the overall groups in comparison. There was a 17% increase in grade 3 adverse events in the Y90 combined group. No more febrile neutropenias, and we've reviewed these with our oncology colleagues, and these are all within acceptable range when you look at these outcomes, probably further to discuss during the Q&A period. One of the issues that arises with these therapies is post-progression treatment. This is unavoidable, of course, and you can see here that over 50% of the patients received some sort of post-progression treatment, of which, of note, in the control group, 13% of them received Y90. So they're being counted as not receiving Y90, but yet they did receive Y90 in the overall survival analysis. This is unavoidable, but something to note, and I think is very important detail for the manuscript for context. This is a post hoc analysis that we just showed at the ASCO GI meeting in San Francisco. Time to deterioration of quality of life was no different between the groups. So the addition of Y90 to chemotherapy did not negatively affect the overall quality of life of the patient. A very interesting curve here, the time to subsequent therapy, very significant between the two groups as a post hoc analysis, much longer in the Y90 group compared to the chemotherapy group. Statistical significance here, where the patients were able to receive longer and not switch to something else in the Y90 group. Post hoc analysis, something that we'll discuss probably in an upcoming manuscript. Very briefly, I want to show an example since we are at a tumor board. A 68-year-old patient, cardiac comorbidities, had surgery before with a poorly differentiated adenocarcinoma, RAS mutated, received 6 months of adjuvant FOLFOX. And this is the scan. So multiple bilobar disease here that you can see, multiple lesions, and no extrahepatic metastases. Was entered in Epoch Trial, and here are the follow-up scans. So you can see here, multifocal bilobar disease. As we follow, he achieved a complete response at month 18, was able to receive full dose standard of care chemotherapy, and achieved a CR. developed a progressive lesion at month 21 and went on to receive another treatment. So this is palliative tent, but can be can benefit some patients, obviously depending on patient criteria and of course technique of Y90. So to summarize, Epoch is the first positive phase 3 study of Y90 and chemotherapy in the second line setting, and the rationale that we selected then was to see if we could extend, given the limited number of treatments available for CRC patients, to extend that timeline. It appears to have done that. The hazard ratios are compelling, 0.69 and 0.59, no difference in overall survival. Overall response rate increased by 70% and nominally significant there. Comparable adverse events, although there are a few that we can discuss a little bit later on. And Y90 did not appear to compromise the ability to achieve chemotherapy. So I think just some things to open up for some discussions. I'm going to bring up a few things that I'm sure will be brought up by the panel. But I think context matters. So the first thing is we're very proud of the amount of detail of imaging and potentially an imaging surrogate detail that is provided in Epoch. This does not appear to be provided in many of the studies, disappointingly, on colorectal cancer. How many lesions? Where are they? What is the location of the disease, et cetera? And this is really provided in Epoch. And so this may provide us with some further post hoc analysis. Fair criticisms have to do with the study design. Is PFS as the primary was that the correct endpoint 10 years ago? It appears that it was, even retrospectively assessing it. There's an improvement in the objective response rate, even with a 25-day delay of receiving Y90 and 13% not receiving Y90 in the Y90 arm. Now, some people have addressed the toxicity, which I think is a self-inflicted complication, because if you're going to do overall PFS, you need to treat all the disease at the same time. And frankly, whole liver Y90 is not best practice. It never has been. It's always been one lobe first, you wait and see, and then you do the other lobe. And so now, in the spirit that you see even with systemic therapies, the principle of dose reduction applies. And so we always do lobar Y90, the most dominant one first, and then you wait to see how the patient tolerates and do the second one. Notice that I also highlighted a more robust follow-up in the Y90 arm. And that's because when you progress, the patients that were on the control arm went on to something else, are no longer followed, but in the TheraSphere arm, they're followed lifelong. So it's more likely to be to attribute a toxicity even 2 years later to Y90, whereas that's not possible in the control arm. The statistical interpretation, again, I think context matters. People are highlighting the medians. In fact, with KMs, it's the hazard ratio that matters. And I think a hazard ratio of 0.69 and 0.59, those are quite competitive and compared to other types of systemic therapy hazard ratios, albeit imaging and not overall survival. It's interesting that the focus, there's been disappointment that the secondary endpoint was not met of overall survival, was not powered for that, was not designed for that, but people are disappointed from that. I'm sure I'll hear that today. And there's post-treatment progression. Many patients in the control arm received Y90. So one question that might come up later on is overall survival a feasible endpoint with local regional therapies? We don't have that with resection, and we have that now with hepatic artery infusion. Certainly there's a lot of people that are focusing on hepatic artery infusion now, although there are some toxicities there that might limit future treatment, such as systemic therapy or even surgery. And so in my opinion, even though this was a study that met its first endpoint, there is a place, I think, for Y90. And again, I'm interested in criticism of this and constructive commentary, is that, invariably patients want a chemotherapy holiday at month 14, 15, 16. And in patients that have liver only or liver dominant disease, this is a reasonable option. In the salvage setting, when everything else has been exhausted, given the fact that without affecting quality of life, we can prolong time to progression and PFS, I think there might be rationale to use that in the salvage setting. And something very interesting as a comparison to, for example, portal vein embolization, is there a role to use Y90 instead of, or in addition to portal vein embolization, because 30 to 40% of patients after portal vein embolization never go to resection, and that's mostly because of progression. So can we use the advantage of a delayed PFS and a TTP in Y90 to potentially identify a niche treatment patient population prior to resection? Thank you for your attention.
Hello, this is Jan Schmidt from Zürich. Thanks for the presentation, and thanks for giving us another tool in the fight against these bad cases. Actually, with Oliver Dudek, obviously you know him already. We have a good interventional radiologist here who's helping us these patients, and we have seen quite some good responses by using these TAR treatments and especially in HCC, actually, astonishing. But what is the background of the you said the metastases are mostly hypervascular, and so we postulate that we have a preferential accumulation of the spheres in these metastases. But we also see many hypovascular metastases, especially after systemic treatment. And I think that's a point that might compromise the effect, and maybe the sequence of the treatment should be first the TAR and then the systemic treatment, because you have a much better vascularization. What do you think about this?
Well, I like that rationale. That's a rationale we in interventional radiology use all the time, although it is often not appreciated on the systemic side because of the level of evidence with systemic therapy. You're absolutely right. In HCC, the results are quite compelling because of the vascularity. And in colorectal cancer, depending on the amount of systemic therapy exposure, that vascularity may in fact become 1-to-1 or less than 1. Avastin, for example, we've seen that change. And so in options when it's feasible to stop for example, the VEGFs, the anti-VEGFs, that's what we recommend. Instead, in fact, immediately after this case, that's what we're doing. I'm doing a patient with colon cancer off her Avastin. That would be the way to do it, and then add the VEGF afterwards. And in fact, we could see in the subset analysis, patients that received a biologic after also fared quite well. So yes, you want to optimize that vascularity by limiting that, if possible, for a month, maybe a month and a half, if feasible, if that's the path you want to take.
Do we have any data from humans that actually you have enrichment of the spheres in metastatic tissue and compared to healthy tissue?
Yes, we have. Yes, that data is contemporary because now that we've adopted cone beam CT, and for the non-interventionalist, cone beam CT means you put the catheter in the hepatic artery and you inject the liver and you do an immediate CT scan at the same time. You in fact see that the tumor and the periphery is very vascular compared to the normal parenchyma. Now that difference is not as significant as HCC, for example, but it's clearly 2 or 3 to 1 compared to 5 or 6 to 1 in HCC. So yes, we have imaging data of that, absolutely.
Okay, just regarding first line, I mean, there has been 3 big trials, Foxfire Global, and CeoFlox, and it's, the meta-analysis, all of them was negative. So using it in the front line, I'm still very skeptical because this was done. Can you perhaps say something about how to use it in well-selected patients? Would you say that it can be really used together with chemotherapy? Is it safe to be really used so close to chemotherapy? Because Oliver always wants to have a break, it's first and then so I think it's also possible to do it together.
So I've never been a fan of Y90 in colorectal cancer in the first line. I think there are just too many options. You want to be able to maintain that for the patient. If you do whole liver, there may be some long-term injury, and that prevents the patient from benefiting from that continuum of care that I mentioned. And that's why when I approached the company to do a second line setting, there was interest in that, because everyone knows your best shot in colon cancer is the first line setting. Once you get to second line setting, the PFS is 4, 5, 6 months, depending on the series you look at. And that's why there's clearly a niche. To me, I don't know. I mean, I'm obviously the co-PI of this study, and I'm very enthusiastic about the results. But even to me, I think that we have to be cautious as to when we use this therapy. And frankly, I think a chemotherapy holiday in the second to third line place is a very reasonable place where many patients ask for some type of break. I want to take a vacation. I'm a little tired. I want to take the summer off, et cetera. That's very reasonable. And frankly, I think in the salvage setting, there are many patients that are floating around that have liver only or liver dominant disease in the salvage setting, where I think one treatment of Y90 might be quite beneficial. I don't have the evidence for that because we don't do a salvage study, but I have to extrapolate from the finding that the PFS hazard ratio is 0.69 and 0.59, 0.59 in the liver. That's quite compelling. So if someone has liver-only disease, that's a 41% risk reduction with it, which I think is significant. And for surgeons, in case there are surgeons listening, I would love to do an analysis where we compare to PVE, because PVE is certainly the gold standard prior to resection in colon cancer. The problem is 40% of them don't get resected. They progress, something else happens. And so you've done 40%, 40 PVEs out of 100 potentially needlessly and jeopardizing something else. So I think there's a lot of place to take this technology next.
Okay, can you say something regarding safety, how to use it? I mean, together with some, how do you normally do that?
So you're right. So we report, we're very transparent. We report 4 grade 5 AEs compared, 8 in the Y90 arm and 4 in the control arm. And part of that, in my opinion, is because we have to do whole liver treatment, right? As part of the clinical trial design and in agreement with scientific principles, you can't do a local regional therapy and have treated and untreated disease simultaneously. It doesn't make any sense. So we had to do whole liver. And as a result of that, I think we had to absorb some extra adverse events with some whole liver decompensations. And that was part of the limitation of the clinical trial design. The reality is, since I started doing Y90 20 plus years ago, I've always done lobar treatment, right lobe, left lobe, depending on how the patients tolerate it. So I think that we take this information, we recognize that whole liver is unnecessary in most cases, and you do one lobe and you see how the patient does. If they tolerate it well, then you do the other lobe, as opposed to taking that unnecessary risk. The other thing I would say is, if you because of this trial, we followed the Y90 patients lifelong. So there are adverse events, for example, that we're reporting that are due to the Y90 that are 2 years out. That's full transparency. Is that really true? There's a difference in follow-up because patients in the control arm just basically leave the study and go on to something else. So reporting equipoise was not necessarily there. It's hyper-reported in the Y90 arm.
Okay. Good. So I think that's gives you make a clear point for the treatment in those selected patients. Of course, the overall survival is disappointing. We do have many chemotherapy trials.
It's disappointing. I'm disappointed.
Because of the second line. But I was quite intrigued to see how long the treatment break can be. I mean, the time to this next therapy, I think that's quite intriguing, that you can really give those patients a little bit more time for the next treatment line.
Right. But if you look, and I think that's a fair point. But again, look at how advanced those patients were, right? I showed you 65% of patients had 6 lesions or more. And those are more difficult to treat. And maybe those patients that have this much disease, it's hard to do a holiday. But if you've got 2, 3, 4 lesions in a unilobar manner, and the person wants a chemotherapy holiday, there's rationale there to give that person 2, 4, maybe 6 months of a holiday, given the benefit that we can accomplish, particularly since the subset analysis showed the fewer the lesions, the better the benefits you're going to get. So there are subgroups there that might benefit from that.
Other questions?
Yes, Riad Thomasani, I'm a nuclear medicine physician and radiologist. I have a question regarding the extrahepatic disease. How did you really exclude it? I'm pretty sure that you had a lot of patients who had still extrahepatic disease, and this is what the patient is going to kill, honestly. I don't believe that it's the liver. So do you really recommend to do somebody who has lymph node metastases in the portal hepatis or retroperitoneal, that you're going to say, no, I'm not going to make something like this on the patient like that?
Boy, you hit a really sensitive spot, because we were trying to, at the beginning of the trial, we wanted to be liver only, but then at your tumor board, you see a small nodule here and there in the lung, etc., and it paralyzes people. They say it's extrahepatic metastases. The benefit we had in this case that the first line treatments didn't have is we have old scans. But still, sometimes the old scans are still difficult to interpret. Was it really there? Was it not? And so my feeling is that some of the lung lesions that were present, and if you look at our baseline characteristics, 50% of patients had some sort of lung lesions. I think many of those were in fact metastatic lesions, but treating the liver might provide that benefit. But there's no way that we were 100% accurate in eliminating all metastases. For sure, we were off and we were doing the best of our ability. But we wanted to enroll and get the trial done, because if we had no lesions elsewhere, the trial would have taken another 20 years, and everybody would be retired by then, and everything would be meaningless.
I have also one question that goes in a similar direction. So if you have a patient that has, let's say, oligofocal peritoneal carcinomatosis along with the liver, would you still consider him giving the Y90?
I'm sorry, I didn't hear. Lesions where? Lesions where?
But we see, if he has a few lesions of peritoneal carcinomatosis, let's say after operation or so, would you still go for the liver treatment then in these cases?
No. So obviously, I mean, there are cases I think where the biology is going to win out. So something like peritoneal carcinomatosis, something like large portal lymph nodes. I probably would not. Now there is one exception. And the exception to that is there is not an uncommon scenario where, for whatever reason, the systemic chemotherapy is holding everything stable, but the liver lesions are growing. Right? That's a scenario that is not that infrequent. And in that scenario, breaking that rule makes some sense, because you keep them on the chemotherapy. This study shows that you can do that, keep them on chemotherapy, and now, to Hat's point, reverse the effect on the liver, because presumably the liver will have a negative effect on survival as well. So in some cases where you have progressing liver but stable extra, I think there's rationale to consider it. Absolutely.
Okay. We try to approach it always, we look what is the most likely cause of death, what is the life-limiting lesion. If
Yes.
The liver, which is in most cases the liver is,
Yes.
we will treat, and if it's elsewhere, then we would probably not do it.
I have a question, if I can ask, because I wanted to know if you guys wanted to comment on, if you had any comments on the editorial that was written about the paper. I'm sure you all read the editorial.
Everybody, I'm sure. Can you repeat the editorial?
Oh, yes.
There's not that many medical oncologists. There's only two or interdisciplinary. But what do you want to, or what was the point you want to make regarding the editorial? Because of the criticism of.
Well, I think that's why sort of I'm as I speak about this is not a perfect study by any means, and that's well acknowledged. The problem is it's a local regional therapy mixing with systemic therapy. It's very complicated to do that, right? There's a reason why there aren't that many resection studies, for example, in combination. It's very complex. I mean, I just wanted to know if you guys thought it was reasonable, without the right context, to expect an overall survival benefit, even with the crossover, the toxicity reporting, even though the reporting was not equipoise. Do you think that's fair, just because it's learning for me as I move forward to see what else to do with this technology?
Yeah, I think, because there are second-line therapies in the medical oncology field, so just a drug treatment where you had a positive effect, you still do expect that in a way. But, as you mentioned, there are other points to consider as well, like the treatment, the time to next treatment, and the local control you can achieve. So this is also value. So I think it's not completely fair just to always request an overall survival benefit. But still, it is a really hard endpoint. And when we play negative, one does consider, and the crossover, what you mentioned, I think is too few. Only this 13% who received in chemo have also received TAR is not really so convincing to people. But I think if you do select really well and good, this therapy is really efficacious, and you showed it also on your case. I mean, this is not something which is that rare to see. And our point is to select really nicely those patients which will really benefit, and that's why we also happy to discuss that with you, because we have to pre-select, and that will be the art of the treatment of the patients, to really pre-select them for the best treatment.
I understand. I appreciate that. I just wanted to confirm the 13% crossover control to Y90 is not convincing to you. You said, is that right?
Right. Yeah, it's too little.
It's too little. Okay. Too little.
Yeah.
Okay.
But the problem is still that we have a turf battle all the time, and we don't have the guidelines. When are we going to use the Y90? That's why often the surgeon says, no, we're going to operate, and there is no, right now, there's the knowledge base is low, and I believe we need to have some advocates to say, wait, we need to do this in this patient, we're not going to surgery, and since it's pretty soft, I believe.
Yes, now we are trying to individualize in HCC patients radioembolisation, and you have done, and your team have done excellent work to really do radiation segmentectomy and in HCC patients, which really excellent long-term results. In terms of dosimetry for colorectal in this trial, how did you do that? Was that one compartment model and just give 100 gray to everyone, whole liver, and just let them go? Yeah, or what was a protocol for dosimetry?
Oliver,
because this is really now the topic,
yes.
which is decisive in terms of complications of
Yes.
radiation-induced liver disease. You give too much, or tumor progression, you give too little. Yeah.
So I think that's a very fair comment, Oliver. This is clearly the thing, but again, this was designed in 2010. We were using merged single compartment dosimetry back in 2010. We didn't know as much as we know now. It took us 10 years to do. Unfortunately, we do not have any detailed multi-compartment dosimetry. It's all single compartment, and that's clearly where we need to go next to minimize the risk of those injuries that can happen if dosimetry is not done. Now, my only answer to that is that we now take this information with whole liver and do a dose reduction comparison to systemic therapies. So that means lobar disease, lobar approach. And I've always been an advocate of lobar technique rather than whole liver technique. And I really mean that part of this was self-inflicted, that we had to do this for the endpoint. So there was a price to pay, the toxicity to meet that endpoint. And so now it's about lobar disease and selecting the right person for the second treatment to make sure they don't undergo any type of liver decompensation.
As from the results of the trial of your subgroup analysis in terms of KRAS mutation, in terms of primary tumor location, which is a little bit in conflict to the results of the Zürich trial, where the primary tumor location was the ones who had in the subgroup analysis the better results. I would be interested to hear from you also your personal opinion of what could be the results for this discrepancy, and where do you see in your tumor board as a result of the trial a subpopulation who could benefit from a more aggressive treatment in the second line?
Oliver, you asked great questions. I don't know that I have an answer as to why the KRAS finding is in contradistinction to other studies. It is counterintuitive, but that's what we found. My philosophy is that when properly done, radiation therapy to a tumor should be agnostic to any type of molecular markers, right? I mean, if you put in, take your HCC example, if I can put in 400 or 500 gray in a lesion, it should not matter, what the molecular biomarkers are of that. So we don't really know. But to Haf's point about turf battles, right now, to be honest with you, we are in a hepatic artery infusion turf battle. That is what is being advocated and used very frequently. We see a lot of biliary toxicity and a lot of progressions. I'm not sure I can entirely explain the rationale. I don't know if you guys have that resurgence of the hepatic artery pump in Switzerland, but it's got a huge resurgence here in the United States. And you're right, Oliver. At the end of the day, it's about patient selection. To me, I've never advocated, nor does the discussion talk about universally adopting this for second line setting, but rather properly selecting patients. And I think the chemotherapy holiday, the salvage patients are a very good patient cohort for this, respecting the fact that it's not proven in level 1 evidence, but at least a proof of concept is there in a very strong randomized phase 3 study that there's anti-tumoral effect, delayed in progression with a good safety profile when done properly.
Okay, Riad, thank you very much. I think these were really valuable points. Perhaps you can send us your presentation if that's possible, just
Sure.
for the others also to review.
Sure.
And thank you for the lively discussion, and it's surely a thought stimulating. And we wish you very nice rest of the day. We are now heading off home because it's already evening here. But thank you very much for connecting and for discussing these relevant findings.
Thank you. Thank you for the invitation. It's really an honor. Thank you very much, guys. Bye-bye.
Thank you.
Auf
Bye-bye.
Wiedersehen. Auf
Thank you,
Wiedersehen.
Riad.
Thank you.
Thank
Auf
you.
Wiedersehen.
Take care.
Bye-bye.